Good afternoon, everybody. My name is Jean Fajadet. It's a real pleasure to work with my partner, Bruno Farah. And today we are really talking about a major improvement in the PCI technique. We talk about the robotic PCI. Why it's impressive? Because it's certainly one of the major advance, and for the future, it could be the future of coronary intervention, and maybe we could find in the future an indication for valvular and structural intervention. We will try during this PCR event to show you what we can do at present time with the robotic PCI and what are the advantages of this technique. So we will have a brilliant panel with Helge Möllmann, Holger and Grantham. We will show you 4 different consecutive videotapes, and between each videotape, we will have some time for discussion. So I see that Helge and Holger are already connected, so thank you to be connected with us. And I will thank, of course, Siemens to make this session able to be ready for this EuroPCR. So, what we will, before starting, we will say that for all of you, do not hesitate to ask questions. You can use the chat. We have our chat master with us, and Bruno. We will receive all the major questions from the chat, and we will, together with Helge, Holger, Bruno, and myself, we will try to answer honestly with what we know at present time on this new PCI technique. So I think that we can move to the first videotape.
We will discuss today the current challenges in PCI practice and advanced solutions to address them. I have no conflict for this particular lecture. In the last 40 years, we have major improvements in PCI technique in order to improve the result of the angioplasty and the clinical outcome of the patients. This improvement were according to the strategy of the vascularization. This improvement were in the technique of PCI, the radial access, for example, the stents, drug-eluting devolution, drug-eluting stents, the imaging and physiology, and all the system of plaque preparation with atherectomy systems. We have also improvement in medical treatment, particularly antiplatelet and antithrombotic therapy. Today, we will discuss the improvement and the remaining issues and the improvement that we need concerning the operator and the cath lab team. In other words, there are some remaining issues concerning the radiation exposure and the operator fatigue. The radiation exposure for the operator and the cath lab team, particularly for long and complex procedures, CTOs, for example. Operator fatigue concerning the high volume operator and the problem of fatigue of the operator after a long day at the end of a very busy week, and of course, at the end of complex and long procedures. And what we saw, and this experience we had in the last years, sometimes at the end of the procedure, we have a less precision in wiring the lesion, less precision in the stent placement. And at the end, we had a non-optimal PCI technique. So when we think to the advantages of the robotic PCI, there is a question. And the question is the following: can robotic PCI first reduce the radiation exposure for the operator and the cath lab team? Second, can the robotic PCI reduce the operator fatigue? And in addition, can robotic PCI can facilitate the procedure and improve the angiographic and clinical outcome of the patient? So that's the reason why since March 2019, we start remote robotic PCI in our cath lab. And at the end of the last year, in December 2020, we had 200 consecutive patients treated by remote PCI using the Corendus Siemens robotic assistants, and in a particular shape. In other words, all the system was placed in the control room. And you could see here that this is an image from the control room. We have all the setup of the robot, and also on the right part of the slide, we have all the the manipulation of the C-arm. Within the room, it's a very simple installation of the patient, and you could see that you have the arm of the robot just on the legs of the patient, and on the right part, we have the injector for contrast media, but this injector is manipulated from the control room. Here, some picture showing the operator manipulating the guiding catheter, the guide wire, and also the table, and the angulation of the C-arm for the X-ray monitor. Some example. We start, of course, by a single proximal isolated lesion. Here an example of one of the first case we perform with a robot on the proximal LAD, and the result after a single stent implantation. Then progressively, we increase the difficulty of the anatomy of the lesion. Here, a long lesion of the proximal and mid segment of the right coronary artery, treated with implantation of 2 stents. Here, a long lesion of a patient, we have the long lesion of the LAD and right coronary artery. And again, these 2 vessels treated with 2 stents in LAD and 2 stents in the right coronary artery. Here, a patient with a lesion of the ostium of the left main and the ostial lesion of the right coronary artery, again treated successfully with 1 single stent implantation of each lesion. And here a patient with 3 vessel disease with a critical lesion on the OM branch, high-grade lesion on the mid-LAD, and high-grade lesion on the distal RCA. And these are the results after remote PCI technique with implantation of the single stent on the free vessel. We perform PCI in bifurcation lesion, and here with the result with 1 stent implantation in the main vessel. Here a patient with a critical lesion at the ostium of the LAD and the left circumflex artery, and also we treat patient with prior bypass surgery. Here, after a vein graft and disease, and here and the Lima distal LAD to a Lima graft, which was really angulated and there was no problem to advance the wire. Finally, the results were satisfactory with very good immediate and clinical angiography and clinical results. In conclusion, PCI with robotic assistant is feasible, it's safe, it's effective, and we could treat multiple lesions during the same procedure. We could treat complex lesion as bifurcation and ostial lesion. Compared to the manual PCI, the robotic PCI, the gain is that we have no radiation exposure for the operator and the cath lab team. There is a dramatic reduction of the operator fatigue, a precise evaluation of the coronary artery length, and this is thanks to robot millimeter by millimeter, a precise positioning of the stent in ostial lesion, again millimeter by millimeter, and for long lesion, in order to have the minimum overlap. Of course, at the beginning, we have a longer preparation time, a higher contrast volume, and a fluoroscopy time. We were definitely dramatically reduced with experience.
Okay, so this was the video we have performed in Clinique Pasteur after this experience at that time of 200 patients, and now we have more than 230. And what we like to have, it's the opinion of Holger and Holger Neff, and then Helge Möllmann, to know what is really the positive point of the robotic, particularly in the technique. What we felt, and what I say at the end of the video, it's the precision when we have two stents to minimize the overlap. The precision that we have when we have to implant a stent at the ostium of the vessel, the ostium of the left main, for example, or the right coronary artery. This kind of, quite difficult procedure would demand some, precision. And it's true that sitting in an armchair, just moving with the time, the balloon advancing millimeter or removing millimeter, we feel that the result that we obtain are certainly better than manually. But again, it's a feeling, there is no study to demonstrate that. So just if we can have the opinion of Holger and then Helge.
Actually, the precision is exactly what I find remarkable. You already pointed it out. There is no really clinical data around which proves, but there are a lot of experiences now which all come to the same point. The precision is quite remarkable. Of course, the robotic cannot stop the movement of the heart. Nonetheless, it seems to be really easier to precisely place the stent, especially if you have more than one stent to place, or the ostial lesion.
Okay, thank you for your comment. And there is a question from the chat, Bruno.
We have a question from the start about what is the if you have to say how long it takes longer compared to a standard procedure. What's the time delay that you have with the robot?
It's true that it needs time to prepare the patient, the robot, when the patient is on the table, to prepare the robot, etc. So what we did in our cath lab is to have 3 nurses fully dedicated for the robotic procedure. And so we saw that after, what I will say, 50, 60 cases, the time to prepare the patient on the table, the robot, was really dramatically reduced. So it's true that it's something which is real at the beginning of experience, but if we work with a dedicated nurse, and at least 2 nurses in the cath lab, this is a reduction of the time with experience.
As you said before in your talk, there is a dramatic reduction of the operator's fatigue. Firstly. Secondly, we have this reduction of the potential hazards for the operators, thinking about the radiation exposures. And of course, as you mentioned as well, I think that the precise positioning, which is possible with the robotics, is something we have experienced in the past. And as just recently mentioned, we have also, of course, this learning curve. But with this learning curve, we were able to reduce the procedure time as well, the contrast volume. We just doing also a randomized controlled trial, comparing experienced operators with unexperienced operators doing the robotic procedure. And what we can see is that there is a same level of radiation exposure. There's the same level of contrast volume. And of course, we have also measured the geographical miss of stent implantation, which is nearly the same. So there was almost no narrowing at the stent edges with the robotic, because you are very precisely within the measurements. And this is, of course, something of the benefits coming from the robotic system.
Thank you for your nice comment. I think it's time now to see a very nice video from Helge Möllmann's team explaining perfectly how to set up the cath lab to organize the Robotic Pci.
Herzlich willkommen im St. Johannes Hospital in Dortmund. Mein Name ist Robert Hafke. Ich bin Krankenpfleger hier im Herzkatheterlabor. Wir befinden uns in einem unserer 5 Herzkatheterlabore, wo wir auch den Korpass installiert haben. Wir sind hier normalerweise eingesetzt mit ca. 2 bis 3 Pflegekräften, also Assistenzpersonal, und einem Arzt, der die Intervention durchführt. Der Arzt sitzt dann nach dem Positionieren des Katheters hier an dem an der Bedienkonsole, an dem Steuerpult, und wir können jetzt einmal reingehen und uns das System im Untersuchungsraum ansehen. Ich werde jetzt den Roboter aufbauen und die Kassette hier einlegen. Erstmal das zur Seite. Das Display am Roboter zeigt mir jeden Schritt, den ich hier tun soll. Ist also sehr simpel. So, wir haben hier den Coronardraht schon vorbereitet. Der wird jetzt hier in den Y-Konnektor eingelegt. So, jetzt ist der Roboter bereit, dass der Doktor den Draht von außen vorbringen kann. Ich kann mich jetzt in die Ecke stellen und bin auch aus dem Strahlenbereich ein wenig weg. An dem System sind derzeit 2 Pflegekräfte geschult und 2 Ärzte, die das System bedienen.
Hello, my name is Dr. Christian Tesche. I'm one of the senior cardiologists in interventional cardiology at the St. Johannes Hospital in Dortmund, and it's my pleasure to introduce you to our Corindus GRX Robotic Pci system today. The workstation consists of a nice user interface, which is controlled by either joysticks or like a touchscreen, where you can perform your procedures by using either the joysticks to guide the devices like balloons or stents, the guide wire, and of course your guiding catheter. For the procedure itself, you have several features that can be applied. Starting from left to right, you have your device where you can put in and control like your stent when it is placed in the correct location all over the stenosis. In the middle of the workstation, you have the guide wire, and this technique enables several features where you can use like several different techniques for spinning, wiggle, or run through with the guide wire to cross your lesion, and next one to place your stent balloon. On the right-hand side, you have the guiding catheter, which is normally placed before you start your procedure in the cath lab by one of the attendings. The ARTIS Icono angiography system consists of several parts: the C-arm, the detector unit, the huge display, then the cath lab table itself with the control panel. So the most important key feature is the flexibility with this foot area that allows for a ceiling-like procedure performance. Our large display allows for high sufficient image quality and is a keystone for guidance of our procedures.
When we started the robotic program here in Dortmund, we started with a rather small team. So I think it's important to first get some people of the personnel familiar with the system, and then increase the number of physicians and technicians to work with the system. So the robotic family started with 4 people, and now we are growing slowly, and in the meanwhile 8 to 10 people are familiar with the system and are really keen to work with the system, and would like to have the opportunity to learn on how to really work best with the Corindo system. There are a number of clear benefits together with the robotic system. So first, for the patient, I think it's a gain in accuracy. You can really place the stents exactly where you want to place the stents. This may be even more important in long lesions where you have to place several stents. It may be important in really sizing which kind of stent is the right stent. And it may help you in complex lesions with wiring the vessel and bring things forward in a safe way. It then may have a benefit for the personnel, because the radiation dose can be decreased significantly for the physician as well as for the technician, because you have to step back. The physician is probably in another room. The setup here in Dortmund is that we are sitting just outside the cath lab, so there is no radiation at all. And therefore, especially in high volume centers, it might be of great advantage to really reduce the radiation for the physician. The daily routine during Robotic Pci is somehow different from the normal workflow in the cath lab. So we are only dealing with planned PCIs, so it's a more relaxed working compared with the myocardial infarction issue in other cath labs. I pointed out all patients have planned PCI, so we already know what we are talking about. We already can do our plans right before, and we are looking for patients with not the simplest coronary lesions, but on the other way, it should be not too complex. So I'm convinced that we should not go for trifurcation lesions with a 3 wires. So what we can easily treat is long lesions, and here comes the advantage of the system, because we can stent in a very exact manner, and what we can treat is bifurcation, 2-wire technique. All these lesions can easily be planned for Robotic Pci. When we are talking about cases which will benefit most from Robotic Pci, I have especially cases in mind where we need several stents, because it's then very important to exactly place the stents with not a lot of overlap, no gap. That's even more important. And where it might be important to measure the exact length of the stent which is eventually needed. All these issues are nicely addressed with a robotic system, and therefore these patients probably benefit most from such a procedure. My favorite part when working with a robotic system is to sit very relaxed in the chair outside and let everybody other work, especially the roboter.
So very nice explanation about the setup of the cath lab with the robotic PCI. I have two questions from the chat, maybe for you. The first one from Dr. Risanen is about the staff organization. Do you need some extra nurse when you do robotic PCI in the room, or is it the same number of nurse?
Actually, it's less. So we only need one nurse who is really familiar with the system. Of course, it takes a little bit more time to set up the whole thing. But once it is set up, there is no need for an additional nurse, scrub nurse. Therefore, no, this is no difference from normal PCI business.
Okay, thank you for this answer. The other question for Holger is about the feedback that you have with the joystick. It's probably different than the usual feedback. How can you compare this feedback to the standard practice?
No, indeed, there is absolutely no tactile feedback coming from the guide wire. However, I was also a believer of having this tactile feedback, which is very important. But interestingly, with the robotic system, you don't need the tactile feedback anymore because the steps are millimeter-wise, and of course, you have direct response from the imaging that the wire is maybe going in the wrong direction or is curling. So I think there was maybe the tactile feedback is overestimated so far, and you not need that anymore with the robotic.
And about Helge, about the type of guide wire that you use, is this the hydrophilic wire, standard wire? Does it change compared to your usual practice?
No, not at all. We are using exactly the same material. And I think this is important. If you have experience on how a wire behaves, you have the experience not only in your hands, but also in your eyes. And then you can clearly see when the robotic system is working for you. If the wire gets stuck, you can see it very early, can react. And as Holger pointed out, we are working somehow slower. So we go millimeter by millimeter. We try to really get each curve as we want to have it. And it's not so much like try and arrow in comparison to a manual way of working.
Okay, thank you. And now a question for Holger. It's coming from Marcus. Can you estimate the time you need when you have to switch to a normal procedure due to a bailout complication? What's time it lasts when you have to switch immediately for complication?
Yeah, this is a very important question, because if you have to convert to a manual PCI, this can be done very easily within seconds. This is just disconnecting the hemostatic valve with the robotic, and after this disconnection, you can work manually as you are used to.
I think it's time now to move to the next video. It's a video from Holger, and it's a very interesting video about with challenging cases.
Yeah, thank you very much, dear ladies and gentlemen. It's my pleasure to give you a short talk about the robotic system in daily practice, and these are my disclosures. I just want to introduce you briefly to the case, and I think it's a typical case in which robotic systems might be superior over manual PCI. However, let's see. Well, this is a case of a middle-aged lady with an severe stenosis, which is more than calcified. Also, the distal left main seems to be affected, and the iris could confirm that there was a kind of a napking in the osteocirc, which is shown in the middle panel here. And looking at the reference vessel diameter in the left main, so there was RVD right about 4.5 point millimeter, so that we decided to go for a lesion preparation with lithotripsy, supported by our robotic system. So I just want to briefly introduce to the robotic system. This is the console, which is in the control room. You can steer and also manipulate the C-arm of your angio. You have the foot panel also to apply the radiation, which is showing here. And of course, you have some monitors. One is the live monitor as well as the hemodynamics, and you have some view control to the cath lab just to communicate with your team. And this is the setup of the robotic system. And so we could start directly with the case here, and with it shown here. So this was just prepared, and we had selected an EBU 4.0, and here you can see the wiring with the robotic system. You can control the robotic guide wire with the middle knob here, which is shown here. The green knob is to guide your guiding catheter, and the left knob gives you the control over stent devices or balloon devices. And you can see here how easy you can steer and navigate your wire down to the vessel. And this was completely controlled only by the robotic system. If we go a little bit forward for the sake of time, you also may appreciate the fact that we had introduce and advance the second wire in the LAD. Just regarding the guide wire positioning, so we have new software available, and I just want to focus in this short talk about the rotate on retract, the wiggle, and the spin software, which has been introduced. What is rotate on retract? It's ROR, designed for the wire navigation, which automatically rotates the wire when the joystick is retracted, thereby retracting the wire tip, which is nicely shown here. So there was the false direction with the ROR, the rotation, which means 220 degree, could avoid the navigation in the wrong vessel. So this is a nice clinical example where rotate on retract is used. There was the false vessel navigated with retract. There was the rotation by 220 degrees, and automatically we navigate into the right LAD. The other and second software support is the spin, which is designed for lesion crossing. What does it mean? This means the full clockwise and counterclockwise rotation of the guide wire while advancing. This facilitates your lesion crossing. Here was in the silicon model, there was a lesion prepared, and you see how nicely the wire goes down through the lesion. Finally, we have the wiggle, which was a navigation mode designed for wire navigation. That means that you have a combination of the oscillation of the wire while advancing, and simultaneously you have the rotate on retract when the joystick is retracted, and thereby you can redirect the wire tip very precisely. This shows an example of this new wiggle navigation software. You can appreciate how nicely the wire is going that direction you have before decided, and this was very smoothly, and I think it demonstrates the support of the software navigation. This is a clinical example, and with these new wiggling support for guide wire positioning, you can significantly reduce the wire time, which is demonstrated in this nice example. You can see how how easy the wire is going down to the circ vessel. But back to our case. We decided to go for lithotripsy, which is also possible to perform with the robotic support. This was the balloon of the shockwave 4.0 millimeter over 12, which shows a nice expansion. Remember this napkin calcification. After that, we decided for a 3.5 over 28 millimeter draculuting, and you can see that there was some problems, quite difficult to position the stent. However, with the possibility to guide the steering, to steer the guide catheter, which is the green knob, and simultaneously to advance your stent, we finally reach the position which was directly in the ostium of the left main, and thereby, of course, be very precise. And we could use the millimeter steps to be very precise in this case. So just to summarize a little bit, you can see we want to advance. I have used the millimeter steps to be precise. This is now the implantation of the draculuting stent. And if you go a little bit forward, we will see that we had to use the final kiss, and after that the final pot. And this is now the stent implantation, which was fully controlled by the robotic system, and you can see how precisely the positioning was in this case. And this was a 3.5 over 28 millimeters, which was followed by the POT, the proximal optimization technique. Of course, we had to rewire the LED. We did this controlled by the robotic system again, and you can see how easy this rewiring was in the LED. Finally, we had to finish with an kissing balloon, and of course a final POT, which brings up to the final IVUS. And you can see this nice expansion in this severe calcified ostial circ. Of course, you had this eccentric expansion. However, this what I think because of this severe napkin situation. However, the malposition, there was no malposition and an acceptable expansion. This is the final angio showing a very nice result in the caudal and in the areola projection. Well. Finally, I want to conclude the robotic system seemed to be ready for daily practice. With the newest software, we have, of course, some support from the robotic system, and this will facilitate wire positioning. And I think even with high complex or in high complex lesions, we can use the robotic system very effective and safe, of course. And finally, we have to wait and be aware for randomized trials, which have to show superiority over manual PCI to replace our manual PCI in the future. Thank you very much for your attention.
Thank you, Holger, for this wonderful video, and you show really brilliantly what we get from in the daily practice with the wiggle, the spin, and the ROR system for the wiggle, mainly for the distal vessel when we want to place the wire in distality, the spin for the lesion crossing, and the ROR when we have really a tortuous vessel. So this was wonderful demonstrate. In your case, there was this bifurcation. There was a two-wire technique. Can you explain how you maintain the lateral wire? Is it fixed? This is for all our friends. Can you indicate how it works when you use two wires?
Yes, you have the working guide wire, of course, and if you have to change the guide wire, you just fix you can fix it within the robotic cassette, and you can handle this like you can handle this with your manual PCI. You just have to control your guide wires, of course, and but if you do so, it's very easy to change the different guide wire if you are doing a bifurcation.
So you demonstrate, we have a lot of questions coming. We demonstrate brilliantly how to recross the strut of the stent, this rewire technique. Can you explain, do we need some positive angulation, or you can use this double wire and wiring technique for all the bifurcation lesions?
Well, of course, in this kind of bifurcation technique, we want to cross very distally. As we want to go very distally, you have to position the guide wire very precisely, and by pulling back the wire, we could cross the most distal stent cell just for being optimal with the then following kissing balloon technique. And of course, as we try to cross the very distal lesion or cell with the manual PCI, you can do this very precisely with the robotic system. And in my experience, it's somehow more precise than you can perform it with the manual PCI, because you have this very small and millimeter-wise movements, which is maybe a little bit more accurate than it is with the manual PCI.
Okay, thank you. Bruno, we have a lot of questions coming from the chat.
One for Helge maybe about, when you have to change the different system, different device, you go for CT, for IBUS, you use the lithotripsy balloon. Does it take a longer time? Can you maybe explain, maybe this is more complex when you use the robotic PCI?
Is not more complex. It's perhaps a little bit longer, to be honest, because the wire, of course, is in the cassette, and if you have a new device, balloon, be it OCT, be it whatever it is over the wire, you have, of course, to insert it. So you have to take out the wire, insert it, bring back the wire. But this, now we are talking about seconds. It's not like half a minute or a minute, which will be the whole procedure longer. It's really only seconds. Therefore, I think this is definitely not an issue which has to be discussed.
Okay, thank you very much. I think we can move to the last video, is coming from Dr. Grantham of the Mid-America Heart Institute in Kansas City. And if we can have the video, Dr. Grantham, please.
Hello, I'm Aaron Grantham, an interventional cardiologist at St. Luke's Mid-America Heart Institute in Kansas City, associate professor of medicine at the University of Missouri, Kansas City, and acting coronary chief medical officer for Corindus, a Siemens Healthineers company. It's a pleasure to present what's next for image-guided endovascular robotics at EuroPCR today. These are my disclosures. I do receive speaking fees, honoraria, and travel expense reimbursement from Corindus, a Siemens Healthineers company. Today, I want to talk about the integration of imaging with procedural techniques. Our world has never been more connected than it is right now. The technological strides that have been made, even in the last 2 decades, are remarkable. And the global coronavirus pandemic has taught us a lot about more effective and efficient use of technology. Imagine if we could harness this technology and innovation to improve healthcare. Today, endovascular robotics is about precision, protection, and standardization of procedures. Those pillars will remain fundamental to our mission, but what excites me even more is the opportunity to explore the ways in which technology can evolve and how we as physicians can apply those advancements to the challenges we face now on a daily basis, providing quality care to our patients when they need it, where they need it, and with the best possible outcomes. When we think about how we can do this, there are 3 potential areas that stand out to me. One is expanding access to care through remote procedures. The second is reducing variation through advanced automation. And the third is looking at the opportunity to improve procedural workflow and in-room efficiency through integration and synchronization of imaging and robotic technologies. Let's take a look at each one of those areas. One of the reasons remote technology holds potential relates to the aging population of cardiologists and the potential for a resulting physician shortage. Nearly 40% of interventional cardiologists in the United States are more than 56 years old, me included, and almost 25% of them are 61 years of age or older. By 2025, there'll be a projected deficit of 7,000 cardiologists, including interventional cardiologists in the United States. Now, we're not known as a country that is short on specialists, but around the world, shortages exist. Places like India, China, and some places in Europe are already underserved with cardiologists. Experts predict that the workforce shortages will be more severe in rural areas, with greater than 50% of patients in remote areas worldwide right now who already lack access to care. This means the biggest opportunity for remote, at least in the cardiology perspective, is more of a global impact to reach those patients that may have limited access. As cardiology procedures grow, physicians retire, providers will need strategies to meet the demand for high-quality care. Remote robotic access assisted interventions can help improve access and curb the impact of these physician shortages. Providers who are prepared to perform remote interventions may offer needed treatments to patients regardless of physical location, and then these specialized experts can devote more time to complex procedures. Developmental work in telerobotics is well underway. The CorePath vascular robotic technology has already been used to successfully demonstrate the feasibility of long-distance, multi-location remote procedures over existing and developmental 5G networks. The technology was used by Ryan Mader of Spectrum Health in Grand Rapids, Michigan, spanning distances of 200 and 3,000 miles between the operator and the system. Pictured here, Ryan is seated in a remote cockpit housed at AT&T headquarters in Waltham, Massachusetts. A remote robotic arm was placed in New York City and another one in San Francisco, and teams there assisted Ryan, who performed a series of simulated PCIs using 4G, 5G, and fiber optic broadband communication. Ryan could detect no difference in the performance of these procedures through those various, some commercial and some developmental pathways. And the world's first in human telerobotic PCI procedures were performed already in 2019 by Tejas Patel. Tejas was in Ahmedabad, India, operating from a temple on a patient 20 miles away at his hospital in Ahmedabad. Tejas published this work in Lancet last year. This work has demonstrated this future treatment paradigm is feasible and could be a reality within years, not decades. The hospitals who will be at the forefront of driving this transformation are the ones building robotic programs today. And we're now in the pre-submission phase with our FDA in the design of a trial of telerobotic PCI in the United States. Dr. Mader is the principal investigator, and Dr. Alexander Lansky's group is serving as our clinical research organization. We look forward to the initiation of that trial in the very near future. Imagine you could gain access to PCI techniques that some of the most highly skilled operators are using. AI, artificial intelligence, and automation combined are all around us, and robotics is no exception. Algorithms have already been built in robotics based on data we collected from highly skilled interventional cardiologists that, when employed as our technique package, can improve the predictability and navigation, lesion crossing, and delivery of therapy. This has the potential to speed up procedures, which could ultimately have a positive impact on patient outcomes and throughput. But ultimately, automation is just simply a first step. We'll continue to evolve this capability in robotics, and it's going to make us better as we build the next frontier of autonomous navigation and integration with imaging. Here's an example on the left-hand side of the screen of one of those technique package techniques. This is wire spin. So again, we collected information from several interventional cardiologists about how they spin a wire, how fast they spin, how hard they push, how hard they pull back, programmed that into the robot. So when you turn on this function, the wire will spin at a constant speed, like interventional cardiologists who are some of the world's leading experts do it. There are other specific techniques that have been automated as part of this technique package and are now commercially available. We're rolling it out to current customers. On the right-hand side of the screen is a look into the future. On the right-hand screen, what we've done is produce a 3D reconstruction of a coronary artery based upon 2 orthogonal views obtained with Siemens angiographic equipment. We're then able to map the pathway through that lesion. And then once that pathway is mapped, we can synchronize the tip of the wire to the pathway with feedback to the robotic. So as the wire is moving closer to the target, which is a little red dot there that a physician placed by touching a touch screen, we can get the wire to move toward that. And anytime it moves away, it pulls back, rotates, and gets back online. So this is entirely automated wire movement, which can improve efficiency and consistency of techniques in interventional cardiology. Today, you have multiple technologies in your lab, and each one's instrumental in doing the work that you provide. But imagine what you could achieve if they work together and even learn from each other to improve our ability to see what's going on, to make the best decisions about the course of treatment, and to deliver that treatment precisely and efficiently. Planned synchronization between imaging systems and robotic systems has the potential to improve case workflow, in-room efficiency, and a new level of intelligence will enable an integrated angio suite where imaging equipment and robotics work synchronously to deliver safe, more effective, and more consistent patient care. This combination will ultimately inform case strategy and allow us to focus even more on our patients. By leveraging learning algorithms delivered from large population data sets, the integrated system might deliver procedural treatment plans that further reduce variability. We call this prescriptive analytics, a system of providing feedback to operators about how to proceed in a more efficient way. Think about how social media companies use algorithms that examine your online usage and target you for advertising. Well, instead of annoying ads popping up on your Facebook page, we might envision a great advice pop-up in response to a difficulty you might be having getting a balloon across a very tight lesion, wiring through a severely angulated side branch, or even crossing a chronic total occlusion. So thank you for your time and interest today. I'd like to close by saying these are very exciting. There are very exciting things to come in the field of robotics that will address real challenges and help us connect more patients to advanced care.
So fascinating. And I will have just a question for Helge and Holger. Helge first, what do you think about this dream into the future when we could believe that this imaged guiding and autonomous navigation of the wire, it's really fascinating, but it's not far. What do you think?
Actually, I hope that I do not lose my job. We still need the cardiologists, of course, but I think it's definitely not far to have these interventions not based directly next to the patients, but from somewhere else. And this may help to improve the whole PCI world even more. There are still a couple of problems to be solved, of course. First, there must be a physician around to take care of the patient. Second, what do we do if there is a failure? This may still be the case. Therefore, we are still on an experimental mode here, but I'm sure we will be there pretty soon.
Well, I cannot agree more to Helge, and I'm very excited about the possibility to support the PCI itself and think about the semi-automatic processes for the guide wire positioning, for the positioning of your devices. I'm dreaming a little bit of the fact that we could implement artificial intelligence into the robotic system. Think about the fact that the system can learn, that the system may have information about the vessel dimension of the lesion length, and so that we have all this information in in our robotic system, just to facilitate, of course, the decision-making process and to increase the safety of our patients.
Thank you again, Helge and Holger, for your very nice participation to this session. We start by really the basics of the robotic in our daily practice, in our cath lab. We finished by the last video of Dr. Grantham, really dreaming into the future. Maybe we could believe that in the future, from the angiography, we could place some points on the angiography and the wire will descend to the distality of the vessel alone easily. Could do the same, for example, for the lesion. And the stent will stop at exactly at the site of the lesion. All these things that we could not imagine 10 years ago are now very close. And we hope, Bruno, myself, that we will be able to see this evolution of robotic PCI. So thank you again for your participation. Thank you all of you for sending questions from the chat. Thank you, Bruno. I would like to thank Siemens for supporting this and supporting us for this great session at EuroPCR 2021. Thank you. Bye-bye, Holger. Bye-bye, Holger.
Bye-bye, Jean.
Bye.